next topic, which is transplantation in HIV positive patient. And may I call upon Dr. Shyam Bihari Bansal to go ahead with his presentation. 10 minutes followed by discussion of 5 minutes. If we cross that 10 minutes, we reduce our discussion time, so which is not fair actually.
So, good evening, everyone. Dr. Khanna has warned me already, although it is none of my mistake. So, mm, so what? Yeah. So, kidney transplantation in HIV positive patient has been a relative or absolute contraindication for a long time, but no longer now because it's quite common with the advent of combined antiretroviral therapy. And mostly it is seen in African Americans, and it is one of the most common causes of ESRD in young people of African descent in US. And we also did our first transplant in HIV positive patient way back in 2009, was an African patient from Nigeria. And this was published as first report of kidney transplantation in HIV patient in India. I don't know, there might be some before, but this was the first case report. And we had a difficult course initially in this patient. So why we need to do transplant, why transplant in patient with HIV positive patient is done, and what are the benefits as compared to patients remaining on the dialysis. So if you see, we have to compare to know the difference that this is a pre-heart era. If you see, at the end of 5 years, survival was 71% only in patients on HIV, and graft survival was dismal at 44%. So before the advent of heart, it was and it was significantly different from the as compared to the non-HIV positive patient. But with the advent of heart regimen, you can see that this was the multicentric trial, largest trial published so far in patient with HIV positive transplant. As you can see in this trial, the 3 years patient survival was at tune of 88% and the graft survival was 73%, and which was not significantly different as compared to other patients who were not HIV positive. But yet the possibility of getting a transplant was 30% less as compared to HIV negative recipient. This is a analysis which has been part of the SRTR data, and this has been recently published in 2017, and they found that more than 1,400 patients which either remained were transplanted, and they compared these patients with the patients who were on dialysis, and they found that the risk reduction was up to the tune of 79% in the patients who were transplanted as compared to the patient who remained on dialysis. The benefit was less in the patient who were co-infected with SCV as compared to the patient who were only infected with HIV. And this meta-analysis has also shown that the graft and patient survival at 10 years are significantly better to the tune of 55% and 64% of graft survival, which is not different for the patients who are HIV negative. So what are the challenges we face and what we should do in the patients who are going for the transplantation in HIV positive? So there are 3 important aspects of the transplantation in these patients. One is the selection of the patient, then the antiretroviral regimen, and immunosuppression. So this is a standard indication that when should we go for the transplantation in the HIV positive patient. These patients should be on effective heart regimen at least 6 months before the transplantation. HIV RNA copy should be less than 50 or undetectable. CD4 count should be more than 200. But nowadays, many centers who are experienced in doing the transplant, they do even with less than 200 CD4 count. No active opportunistic infection, no prior history of the progressive multifocal leukoencephalopathy or lymphoma or aspergillosis, coccidiomycosis, Visceral Kaposi sarcoma, now it is a relative contraindication, and some center take the patient even with the visceral Kaposi sarcoma, which has been adequately treated. And hepatology evaluation is very important because some of these patients, they are co-infected with hepatitis B or C. We found our patient who were transplanted initially negative for hepatitis C, but later on he turned out to be hepatitis C positive. Uh, but now, even at the 3 months, some of the societies, they recommend that even a stable heart regimen of 3 months, you can take up the patient for the transplantation. Standard screening is required. One should rule out the infection for the latent TB, strongylitis, syphilis, and local practice like West Nile viruses or other viruses which are required as present locally. EBV monitoring is required in the patient who are D plus R minus because chances of the malignancy are higher in these patients, and HPV screening is required post-transplantation. Standard vaccination should be given and completed in these patients before the transplantation. Combined antiretroviral therapy. So there are 3 classes of the drug which are being used. One is the nucleoside or nucleotide reverse transcriptase inhibitors. These are the most commonly used regimen drugs in these patients because they usually do not require any dose adjustment, and one can use after transplant TAF instead of TDF because of the lesser risk of the nephrotoxicity, and they do not affect CNI level. NRTI are the another alternative, but usually they reduce the level. They are the inducer of the CYP4 enzymes, and but not all the drugs, they are the inducer. So they can be used as a second line, but they are not the preferred. And protease inhibitor based regimen has been actually previously used, and that has been the reason of the poor outcome in some of these patients because they are the significantly inhibit the CYP3/4A, and these drugs should be changed over to other drugs before the patient is going for transplantation, because you need to reduce the dose as well as increase the dosing interval significantly when one is using these drugs. And better to use these drugs, replace these drugs with other before transplantation. It has been observed that if you use PI-based regimen, the reports are the outcomes are inferior as compared to the patient who are not on the PI-based regimen, and there is a significant increased risk of allograft loss and risk of death if you use PI-based regimen. Other drugs which are being used, the most important one is the integrase inhibitors, and these are the one that must be in the combination drug along with NRTIs, and you do not require any dose adjustment. Then there are fusion inhibitors and CCR5 co-receptor antagonists like Maraviroc that can be used in these patients, and these are also do not interfere with the levels. Combination of the 2 NRTI, for example, tenofovir plus emcitrabine or abacavir plus lamivudine along with integrase inhibitor is the ideal combination to be used in these patients. And abacavir, lamivudine, and dolutegravir is the preferred combination. And then you can change the regimen if it is a PI based to the non-PI based regimen before transplantation. A brief about immunosuppression. So it has been found that despite being HIV and the patient is supposed to be immunosuppressed, there is a high incidence of the acute rejection in these patients in various studies. And the most important study which I discussed, the NIH-sponsored HIV-TR study, they found that acute rejection rates were 30% in these patients in first year after transplant and 41% after 3 years. So it has been rethought that why these patients are, most of the patients in this study, they had received either no induction or induction with basiliximab because of the fear of the infection with ATG. And but later on, this paper which came out, they have compared 830 HIV positive transplant between 2000 to 2014 and compared IL-2 induction, no induction, and ATG induction. And they found that if you use induction, there was less graft loss and a trend toward lower mortality was seen in these patients. Induction with ATG had lower rates of acute rejection. Induction with IL-2 also had a lower rate of acute rejection as compared to no induction, but it was not significantly different. But ATG induction had significantly lower rates of acute rejection, and that we have seen in African American patients, especially if you don't use ATG induction, the chances of the rejections are high. There is no increased risk of infection. The maintenance immunosuppression, you use standard triple immunosuppression in these patients also because it is associated with less risk of the acute rejection. And you might need to start the CNI maybe a few days before to set the levels in these patients, especially if you are using protease inhibitor PI-based regimen. Which CNI to be used? You should preferably use tacrolimus in these patients because it is associated with less chances of acute rejection. But if you use mTOR-based inhibitor, then the chances of the rejections are twofold higher. The standard prophylaxis should be used in these patients for the PCP and depending or cytomegalovirus, candidiasis. There is a debate whether you should go PCP prophylaxis for a year. Some people give it for lifelong, but recommendation is for a year. Then candidiasis, tuberculosis, MSC prophylaxis, and coccidiomycosis. It will depend sometime on what is the local or endemic infection is. Post-transplant monitoring of the viral load is required, and frequent CD4 T cell count, especially with the depleting antibody. There is some suggestion that if CD4 counts are less than 400, between 200 to 400, then you might avoid giving ATG as an induction because these patients are prone to infections more, and the resistant testing should be done if increase in viral load. With that, I will just finish and invite all of you to attend this webinar of Indian Society of Nephrology with American Society of Onco-Nephrology on 12th May this year. And I know that there is some discussion on onco-nephrology in this forum also, but this is an opportunity to meet with many people who have worked in this field. Thank you.
I must thank you, Dr. Shyam Bihari Bansal, for setting a standard as a secretary to finish on time the talk, and which would be followed by everybody else. Thank you so much. We have 3 to 4 minutes of discussion possible on HIV transplant.
Sir, how much till date you have done?
So we have done 4 or 5 HIV positive transplantations in our practice, and I am personally following 3 patients. The first one, he lost to follow-up because some of these patients, because they are African, so they don't come for the regular follow-up. 2 patients I follow up regularly and they are doing well. But I'm sure Dr. Kher must have some of the patient in his follow-up. So we 5 or maybe more, because I know at least 5 patients that we have transplanted.
I have a patient who underwent transplant accidentally in 1992 with the mother donating the kidney. That boy is still doing well with normal kidney function. With a prednisolone of 5 milligrams and azathioprine of 50 milligrams. He had refused any form of antiretroviral treatment, but he seems to be doing all right.
Yeah, so some of these will do well even on, so the initial reports of the actually transplantation in HIV positive patient they were later found to be HIV positive. So initially transplanted, later found to be HIV positive, and then they had a poor outcome because there was no effective therapy at that time. So obviously that boy was lucky.
Yeah.
How different is the rejection rate in these patients, and how do you treat anti-rejection therapy?
So as I shown that the rejection is common in these patients, and that is actually
Is it more common?
Yeah, it is more common. It is more common. So there are 2 or 3 reasons. They say that the immune system is dysregulated sometimes because the drugs are not, because there's so much variation in the drug level, and that might be a reason for higher rates of acute rejection in these patients. So in African American, we give ATG as an induction. So 2 or 3 patients we have later on given ATG induction, and they did well. And in other patients, we give basiliximab as induction, but it will depend on the overall profile of the patient. But in this, the largest analysis, they have shown even with ATG, the risk of infection was not higher. But you have to be careful. You have to select your patients, and only because of the HIV positive, you should not reduce the immunosuppression or should not, not to avoid induction in these patients. Treatment is standard like other, but the incidence of the steroid resistant rejection was higher in these patients which were treated initially. So you have to use more ATG in these patients.
Dr. Subara.
Is there any difference between the blacks and Indians with
Yes,
HIV?
pardon, sir?
Is there any difference between the blacks and Indians in the with HIV in response to rejection rates and other things?
So most of the actually data is from the blacks, and so that is why the rejections are higher. They're probably we do not have a large database of the this thing, but this is one of the risk factor for the acute rejection, being the black race is the risk factor.
Indian patients of US, did they have rejection?
Indian data
So
in US.
Indian patients, so we don't have needs. We have only transplanted few patients. In those patients, there was no rejection. So there's not a large experience, I can say.
Yeah, we have had one patient who was transplanted with HIV, Indian patient, and had an acute rejection because we had used only a basiliximab as an induction, and that patient but had acute rejection. So, but the numbers are, as Shyam has said, numbers are extremely small that you can't make conclusions on this.
Yeah, so we had two other Indian patients in which we did not use ATG. We used basiliximab only, and they did not have any rejection.
I did 5 HIV positive patients, 1 from Kenya and 4 Indian patients. And out of 5, 1 patient died of cardiac and 1 died of TMA, and 3 are still surviving, almost 10 years of follow-up. I have not found any rejection. Infection rate are there, but not very severe infection requiring a hospitalization. Only 1 patient required a hospitalization recently because of uncontrolled diabetes.
28 seconds if you want to take.
So we did 2 patients who were HIV positive Indians, and we used the same protocol, ATG plus tacrolimus, mycophenolate, and prednisolone. The issue was getting the levels in the beginning. So what actually, since the half-life increases, both were on protease inhibitors. So it took almost a month to stabilize the levels. So what I did was I started the patients on tacrolimus about a month before the intended transplant. And since the half-life is longer, so usual 3 to 4 days doesn't work in these patients. We need to wait for 8 days, 10 days before we see a stable level. And so it took almost a month to stabilize, and they were like, one was on 0.5 milligrams thrice a week, other one was on 0.25 milligrams 4 or 5 times a week, and which was, so that helped in getting the good appropriate level before transplant. And the other immunosuppressants were given as we usually do before transplant. And both of these did quite well, actually. Only one person got succumbed to pneumonia when he went out to campaign for his political boss. The second lady, we lost it in this COVID after she got mucormycosis.
Thank you, Dr. Bansal. I
Thank
think we'll finish the HIV part here. It's